Sai, thanks for joining us. It's really good to see you. I haven't seen you in a few years, and I know you've been busy. You're in Buffalo. Buffaloes fan. I've heard you're a die-hard Buffaloes fan.
Yes, it's interesting. It's now 5 years in the making. Growing up, it was always cricket, but now it's the Bills.
Are you guys going to make a run this year?
We say that every year, right?
Turning into Cowboys fans?
No, 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 never. But this year we're optimistic. We're optimistic every year, but this year particularly so. I think we came close last year.
That's great. How long
Yeah,
have you been in Buffalo?
18 years.
Wow. And you are chief executive officer of your hospital group, correct?
No, so I serve different roles in the at Roswell Park, and as you know, Roswell Park is sort of the country's first standalone cancer center. Storied history. What I do there is a few things. One is I'm the chair of thoracic surgery, and that's my sort of baseline profession. I'm a thoracic surgeon, trained out of MD Anderson, came here 18 years ago, and I've been doing that ever since. And then Roswell Park has a main campus, and it also has a network. So the network is a standalone legal entity called RPCI Oncology PC. It's what's called a captive PC, and it's a common entity for many health systems. So I'm the president and CEO of the captive PC. And apart from that, I also serve as a senior vice president for business development and outreach. So practice acquisitions, partnerships, clinical partnerships, and so on, they're all designed and run through my office.
So are you in the M&A space? Are you acquiring?
Only from on a small scale, individual practices that make sense for us, that is complementary to our larger mission for cancer care. So my group does the acquisitions, but we also partner with a number of healthcare institutions, and that partnership base is growing, and that also runs through my office.
Will you do an acquisition of another cancer treatment center or maybe a cancer treatment drug?
Usually when we'll acquire individual practices. So it's typically physicians who don't want to deal with the administrative burdens anymore and are aligned with Roswell Park's mission, or practice in an area that's complementary to what we do on the main campus that are sort of cancer adjacent. So we would acquire those practices. So usually they're practices outside of the Buffalo community. Again, this is not unusual. This is part of a large sort of consolidation movement that's been happening in healthcare, I would say, for the last 30 years.
Just like a tech company like Salesforce Ventures or any other company that has a venture arm, is that really what you can classify yours?
It's not a venture arm because venture arms do something different, right? You're essentially placing bets on a sort of a startup, and it may work or it may not work. This is not that. This is mostly practice acquisition.
As a thoracic surgeon, can you explain that? What do you do day to day? What does that look like?
So thoracic surgeons are typically are surgeons who operate on the heart and lungs and anything between the neck and the diaphragm. So it's typically mediastinal masses, diaphragmatic surgery, esophageal surgery, lung surgery, and cardiac surgery. And in the academic world, the initial bifurcation, even amongst thoracic surgeons, becomes whether you're doing cardiac surgery or primarily not cardiac thoracic surgery. And so I made that decision early on in my career that I wouldn't do cardiac surgery, even though I trained at one of the premier cardiac surgery places in the country, if not the world. So within thoracic surgery, which is non-cardiac thoracic surgery now, there are practices that focus on transplant versus everything else. And I don't do transplant anymore, even though I trained with the person who sort of did the world's first transplants. But I don't do that anymore. My practice is entirely devoted to cancer work, and that's why I'm in a cancer center. So currently I operate on cancers of the lung, esophagus, anything in the chest. I mean, mediastinal masses, that sort of thing.
Most of your patients, do you deal with them from beginning of diagnosis to
Yes.
end? Oh,
Yes.
so you're walking them through the whole process.
Through the whole process. So when you look at cancer programs across the country, right? So if you're, say, at MD Anderson or Memorial Sloan Kettering, typically the patients come from not just locally, but they come from far away, and they typically have a diagnosis, and they're coming for a second opinion, or so on. But for us at Roswell Park, we are very embedded in the community here. So we take care of patients who don't have a diagnosis to start with. They have a suspicion of cancer, but we will walk them through the entire diagnostic pathway, take care of them during surgery. We're part of a multidisciplinary group, right? And that's the beauty of a cancer center. I probably talk more to my thoracic medical oncologists that are basically physicians who deliver the chemotherapy or the immunotherapy for these patients. Then I talk to other surgeons. But then we walk them through the surgery, the chemotherapy before or after that may be required, and then we even walk them through survivorship and so on and so forth. So the whole spectrum, the whole cancer journey, we support patients.
It has to be extremely difficult to deliver bad news, to walk with this person, almost get to know them a little bit. And if you lose them, it has to be a big weight. Give us your perspective on delivering the first, second in your career, and then the 100th, if you're at the
Yeah.
1,000th. What does that feel like?
So whether you're delivering this news the 1,000th time or the first time, right? It has the same impact on you as a person. It has, obviously a much larger impact on the patient, right? Because for them, it's once in their life. But this is the thing, right? Is that we approach this job, most of us in this profession, we approach this job with optimism, right? We are happy that we find a cancer and we can take care of it for them. And I would say 20 years ago, when I started doing this, the outlook for lung cancer was much more dismal than what it is today. For one, we're detecting cancers much sooner. 50% of all the surgeries that we do on, or all the cancers we see, in fact, are all stage one, which means they can get surgery. It's typically minimally invasive surgery, and the cure rate is very high, 75, 80%. And then the remaining patients, we now have many more options than we did 20 years ago. I mean, it's quite an exciting time to be in the position where we are treating lung cancer because there's a lot more hope that we do. So our job is to be optimistic, for patients, and there's reason to be optimistic and to convey that optimism, right? Because things happen in life, but we can fix it. We can optimize their quality of life. We are privileged to be able to do it.
When people are diagnosed and they go through the treatments or surgeries and we'll say cured, are they back to normal? Can they resume normal life things? Do you have to see them once per quarter, once a year?
So for those patients who just need surgery and nothing else, they go back to their routine life. Now, they're not going to be athletes. Most of the patients who come to me are not athletes to start with. The average age of the patient I operate on is about 68. So they're older people, but they go back to their what they do on an everyday basis. And this is largely facilitated by our adoption of minimally invasive surgery, right? In the past, when I had to do an operation, this is now 20 years ago, right? We had to make a big cut. We had to divide one rib. We had to stretch the ribs to get our hands in there and do the surgery. That is now done less than 10% of the time. 90% of the time, we can do this all through keyhole surgery. We don't divide any ribs. We don't stretch any ribs. And so when you do that, the recovery is, of course, much quicker, much better. Long-term and short-term complications are lower. So it's just changed the outlook for these patients. So most of the time, they get back to what's their routine life. And they do come back for surveillance. We watch them very closely. And typically, they come back every 6 months for the first couple of years and every year after that for life.
Walk me through cutting open a human being, moving a rib, cutting something out. Walk me through that perspective.
It's interesting, right? And this is what is special about surgery. And so going back a little bit in my own personal experience, I went to med school in India at the time. I think even today, you could argue that it's the country's best med school. It's very difficult to get into. I mean, about 100,000 kids apply every year, 34 get in. And so, it was a big deal for us to get in and do this. And it's pretty grueling. But after 5 years of doing that, I wasn't quite sure I wanted to continue with medicine, right? I was thinking about, because my first love was always physics and engineering, and I was thinking about coming back to engineering through biomedical engineering. But I had my surgical rotation, and you see this where you go in and you make this big incision, you take out a tumor or you fix a problem, and it's amazing how people recover and how the problem is essentially cut out of their life. And when I saw that, I felt it was nothing short of a miracle. And that's what held me back to being a physician. If it were not for surgery, I'd be hard pressed to find anything as exciting, to drag me back to the medical field. So that is what prompted me. And the same sense of wonder that you're expressing, right, is making a big incision, cutting a rib, stretching it out, and you think, how does a person recover from this assault? And people do, and it's one of the marvels of modern medicine. And even today, I've done thousands of these cases. It is just amazing to see that happen every day.
It's really interesting just because of the amount of pressure that you're under. Every single decision that you make has a consequence, good or bad, which is parallel to anything that we see as a CEO, as an entrepreneur, building out the systems. What are you thinking when you're in surgery? Are you locked in? Is it muscle memory? Are you focused on exactly what you're doing or what needs to be done? Walk me through that pressure and how you handle that.
It's pressure, I guess, the first 100 cases, and sometimes it's pressure for specific cases. But I can assure you, it's not muscle memory. There's some aspects of it that's muscle memory, but there's a lot of thought that goes in with every step of the case, and it should. So there are some cases that are fairly straightforward, and that's okay. But there are some cases where every millimeter of dissection matters, and every centimeter of decision making matters. Let me give you an example. So one of the things I love doing is tracheal surgery, right? And notwithstanding everything that happens, in modern medicine, the trachea, no one's found a substitute yet. So when there's, for example, a tracheal tumor, and trachea is the windpipe, it's the larynx at the top, and it goes down and it splits into two, and it supplies each lung with that. So the trachea is roughly about 11 centimeters, and depending on the patient, you cannot take out more than somewhere between 4 and 5 centimeters of the trachea, because if you take out more than that, it doesn't come back together. And sometimes you're not 100% sure how well it comes back together until you've taken the trachea, that portion of the trachea out. So you can imagine in that sort of situation, 5 millimeters this way or that way can make all the difference in the world. So it requires a fair bit of judgment and expertise and technical skill. The technical skill is actually the easiest part. The judgment is the most difficult part. As I tell all my fellows, right, 90% of the outcome of a case is decided before the knife hits the skin.
Why is that? Unpack that. That's
Yeah. So
interesting.
because have you picked the right surgery for the right patient? Is the approach the right approach? Have you considered all the alternatives? In your mind, do you have a sort of a flight plan, right, for what's going to happen the next few hours? And do you have alternatives for it? All that thinking has to happen before the knife hits the skin. And that's as important a determinant of what happens after the surgery as before or during, right? So that's why I tell my fellows all the time, right? 90% of that outcome is decided before the knife hits the skin. And a lot of the time you have to make these decisions on incomplete information. And a lot of the time it's a game time decision. And whatever happens, the patient and you have to live with it. I have to live with the consequences. So it's not very different than as you being a CEO or being the head of a startup, because you make these decisions. A lot of the time you make them with incomplete information, especially as a startup founder in a new market. You don't know how the market's going to react. You'll never know until you try it, and the stakes are high. It's not life or death, but financially it could be life or death.
So you're in the room. You're really the CEO of the room. You're talking with the nurses. You're talking with do you have an assistant, the
There's anesthesia team.
anesthesiologist?
Yeah.
So are you monitoring kind of the whole situation? Or are you hyper focused on what you're doing?
You're monitoring the whole situation while you're focused on what you're doing. So it's interesting, right? So the anesthesia machine has a beep. It goes beep, 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 depending on the patient's oxygen saturation and the heart rate. And when that beep changes, it slows down, or it picks up dramatically, in the back of your mind, you get used to monitoring that without really monitoring it actively. So the moment I hear the quality of that sound change, I won't even look up. I'll talk to my anesthesiologist and say, "Everything okay up there? What's going on? Talk to me." It's just like you would flying a plane or doing anything else. You're focused on what you're doing, but everything else matters. You know, how you set up the case, how you help your assistant help you. It's interesting because there are lots of parallels between that and management, managing a group, for example, right? You're focused on what you're doing, but you have to sort of pay attention to the peripherals as well.
And everybody's human in that room. Everybody comes in with a bad day. Everybody comes in with a headache, fatigue. I know surgeons can go 24 hours, 36 hours without sleep and still perform at that high level, right?
Yeah. I mean, we're used to that. We're trained for that, right? That's why training in CT surgery, you know, from the time you get into med school to when you become a CT surgeon, it's about an 18-year journey. So this is a long time, and it's physically and emotionally and psychologically grueling. So it weeds out people who don't want to do that or, you know, can't do that. As a surgeon, you learn a lot of things about leadership, right? You learn how to develop psychological safety with your team. You know, if someone makes an error and it's not because of carelessness, you know, you have to let that go and move on and deal with the consequences and or fix the consequences. Sometimes you have to predict what goes on. For example, you might have a situation where your scrub tech is brand new to thoracic surgery, hasn't done too many cases before, and you're taking on a complex case. So then you will go to the scrub tech and say, listen, I apologize, but I'll have to ask for someone more experienced because this case demands it. And it's not about you or me, but it's about the patient. And the wonderful thing about healthcare, though, is that you don't always see in businesses that everyone in that room cares for the patient. That alignment just comes together. You don't have to ask for it. It just happens. And that's the one thing that's a non-negotiable in healthcare, and everyone understands it. So when I explain that to a scrub tech or even to a resident, sometimes I'll have a resident or a fellow scrub in, and it's a complex case, and I'll say, listen, I understand you want to see and you want to learn, but this is I need more experienced help. So I will call one of my colleagues to come and help me with that case. And they don't take it personally. Everyone understands. So yes, you have to understand that human element, but you have to control that human element, that variability, if you want to get the best outcomes.
Super important in any, whether it's military, starting lineup for an NBA team, football team. I mean, you have to have the best of the best for that outcome. I'm curious if you could take us back. You alluded to going to med school and really not knowing which direction you're interested in physics. Take us back before that. How did you grow up, and who introduced you to medical health? What's the curiosity? Why?
Yeah. So in India, it's interesting because you have to decide to be a physician or not by the age of 15. Because you differentiate at 15, once you passed what's the equivalent of your sophomore year in high school, you have to pick a path. At least at that time, that was the case. And you have to decide if you're going to be a math major, a commerce major, or a biology major. And most people who took a biology major end up in medicine, and that's why they take the biology major, right? And so at 15, I was sort of trying to make this decision. My first love was always physics and math, and biology was a little bit too variable for my taste. Let me put it that way. But the understanding in my family was my mother, particularly, she believed in that the best way to help people was to go into medicine, and she instilled that sense of service in all of us. Because her mother, there's an interesting backstory to this. Is my grandmother, she just had an eighth grade education, which was common in Indian women at the time. This was going back almost 100 years. And she was widowed at the age of about 52 or 53. She was reasonably wealthy. And she said, well, my kids don't need my wealth. I'm going to take this and I'm going to invest this in the community. And what she did is she built a center for old people who were abandoned by their families. And she did all the fundraising for it. She built it. She managed it. In fact, one of her biggest supporters was Princess Diana. I have a picture when Princess Diana visited India. She actually came to the Old Age Welfare Center and toured it with my grandmother. It's one of my favorite pictures in the world because here is an eighth grade educated lady who couldn't speak English having this impact on the world that was recognized by world leaders, right? And so we grew up seeing this. And so when my mother, uh, you know, um, uh, was thinking about what her son was going to do, she so strongly believed that the best way I could contribute to the world was with doing medicine. And so she urged me to consider medicine. She never forced me, but she urged me strongly. And so I said, okay, fine, I'm going to do this, from that perspective. And I'll tell you an interesting story, Mark, that that my kids had just recently learned. I was 14 or 15, and there was this famous surgeon from the United States, and his name was Denton Cooley, and he's one of the founders of cardiac surgery. And he was giving an interview in India national television, and so I was out probably doing nothing useful, and my mom calls me and she has me sit down and listen to this guy. And I'm looking at him. He is this older gentleman talking about things I had no clue about. And she looks at that and says, this is a guy who's revolutionized, medical care, and thousands of people have benefited from it. You should consider doing something like this. And the interesting end of this story is about 17 years after that, I actually trained with Denton Cooley in Houston. I mean, who would have thought? I have a picture of Denton Cooley operating with me as a fellow in Houston, one of the last cases he did as a surgeon. So it's life has a way of coming full circle. So that was the reason I went into med school. I decided to do that, and in some ways, that's the reason I continue to do what I do in a different way, but that's the motivating factor for me.
In that 17 years, I'm sure there was moments where you thought, is this worth it? Why should I do this? Uh, were there moments where you were saying, "No, I should have been a physicist. I should have been a mathematician. I should have done something else."
Never. So this is the interesting thing. My attitude is once I made a decision, right? Um, I'm blessed in the fact that I never look back. Right? And so once I decided I was going to be a surgeon, I applied to residency programs in the United States, right? And it was interesting because that was not easy. At the time, it was very difficult for a foreign trained physician to get into a residency program in surgery. I remember I was in the top 5 of med school class. I had 99th percentile in all the qualifying tests, and I applied to 300 surgical training programs, and I just got a response from 6. 294 programs didn't bother even responding, didn't bother even rejecting the application. And of the 6, one of them gave me the opportunity. They were going to try me for a year. Right. But sometimes it's great to be young and foolish because I still remember that I walk into that interview room, and this was at the University of Pennsylvania, right? One of the best institutions in the country. And they were trying out this new program where they would take what are called prelim residents. And it was only, I think, the second year of its existence. And I walk in, and one of the faculty members asked me, he says, well, Sai, what happens if you do this for a year and then you don't get a job to finish your surgical training afterwards? And that's why I said it's good to be young and foolish. My response to him was, sir, if you see how I work, you're never going to let me go. So I'm not worried about not having a job after a year. I guess they liked the answer, so they gave me that shot, and that's changed my life trajectory. But I've never looked back. Once I've made a decision, I guess that's just one of the few positive attributes I have is I never look back.
And I think that's the moment where grit guides the way. I'm sure a lot of people have been in that situation where exactly what you're saying. I'm so determined. I don't care what gets in my way. I can care less. I will work under Dr. Cooley. Even though you didn't know it at the time, you saw something, you put it in your subconscious, you're there 17 years later. I mean, that's the beauty of determination and grit. Where did you find your determination? Were you born with it? Or was it instilled by your grandmother? Did you read it?
So my father used to always tell me, he used to say, son, what's the point of doing easy things? Everyone does easy things. He used to always tell me, it is not a sin to fail. It is a sin to not aim high. And I've disagreed on many things with my father, but some of the things he said have always guided me. And that's the fun. I'm not afraid of failing. I'm okay with failure. What I'm afraid of is not trying and not mattering. That is unacceptable to me. And so many things I've done. I've tried things many times, and I've failed many times, and that's okay. I just brush it off. For example, when I was writing grants to get grants for my research program, and I tell this to a lot of young faculty members who write a grant and it doesn't get funded. I wrote 23 grants before my first grant got funded. But the thing is, I wrote 23 grants in 24 months. And it didn't faze me that somebody did fund me. That's okay. We'll get better and we get up and try again. So, like I said, once I decide to do something, I'm gonna. In fact, the trying part, the getting up, part and trying again, that's the fun part. The amazing thing is once you get it, it's okay. But the trying part is the fun part for me.
I've read a lot about various CEOs that are decacorn or billionaire status, and all of them have said what you're saying. All of them said, enjoy the first startup, enjoy the unknown, because that's where the excitement comes from. When you actually don't know, and there could be a real probability of failure, and it probably is going to happen, but the unknown is so addicting that they would do anything to really go back to that moment. Because yeah, you hit the decacorn or the billionaire status, which is wonderful. They definitely wouldn't turn back. I wouldn't. But there's a moment where entrepreneurship or founding a startup, it's addicting because of that unknown. It's a rush, and just like you in the surgery room, every single millimeter, every single centimeter, it counts for something, and you can quantify it in which direction you're going to go. It's about failing fast, but quantifying how to get up and when to get up and where to get up. That's the thing. You can't just keep getting up and trying the same thing over and over and over. You have limited resources, and you in your position being a surgeon, you know this all very well. Being a founder, military folks, sports folks, you have to get up better, stronger, but in the right direction. And it's super important.
It's just like practice. There's intentional practice and there's just practice. That's not just practice doesn't help. Every time you do something, in order to get better, you have to review, you have to be honest with yourself, which is difficult to do. And you say, well, what did I do wrong? How can I do this better? And that is what counts. When I went back in the middle of my career to India to set up a thoracic surgery sort of division in India, right? That was very much a startup, and it was a great experience for exactly what you're talking about, right? We had no idea of how to do this. Nobody had done this, but that was the fun part.
Can you walk us through what you built?
So this is how it went. So I finished my training, joined faculty at Roswell Park in Buffalo. And it's 6 years in. I just became an associate professor a couple of years ago. My research was going great, and my clinical practice had taken off. And at that time, so I've always wanted to go back to India, sort of my way to give back. And the problem I saw when going back to India, is cardiac surgery was quite well developed, but general thoracic surgery really wasn't. There were a few people who were doing this, mostly in North India and some in down south, further south, down south in Hyderabad, but which is where I come from in India, but nothing in Hyderabad at the time, or nothing in the state of 60 or 70 million people. So I said, well, I really wanted to go and teach and build something. And I realized that going periodically and teaching really just wasn't going to cut it. So if you're going to make a dent, it's worthwhile to actually go there and do this. Talked to my family, and we decided, okay, it is worth doing this for a few years. So I go to the administration of Roswell Park and say, listen, I'm quitting my job, and And I've sold the house and sold the cars, and we're going with the family and the dog and going to India to do this. And the person there, who is now the current CEO of Roswell Park, Candace Johnson, and she says, Sai, if you're going to go to India, go, but don't quit your job. We'll give you an open-ended sabbatical because when you're ready to come back, we want you back on faculty here. And what you're proposing to do in India is consistent with the mission of Roswell Park. And so there's no reason for us to eliminate your position. I think we'll handle things until you get back. And so that shows the heart and soul of both Roswell Park and our CEO, right? And I was very grateful for that. And so I went to India. Now there's nothing there, right? I mean, there was the hospital I started didn't have a blood bank for the first year, right? They were just building the hospital, which is why I didn't have a blood bank. Otherwise, in India, there are modern hospitals and so on. But I wanted to sort of grow with a hospital, right? And sort of instill this in the beginning of a hospital, a different sort of work culture and so on and so forth. I felt that if I went to an established hospital, I would have to fit in with their mold rather than trying to do this. And it was a risk. So we went there and there was nothing there. And I was one of the first surgeons being recruited. But there was a lot of well-meaning, qualified people. So I got a group together. I had no formal title or authority, but I got a group together to say, anesthesiologists, ICU physicians, medical physicians said, hey, I want to build this thoracic surgery program. Why don't we partner and do this? And everyone was enthusiastic because they're all well-trained, well-qualified people. And well, but where was the business going to come from, right? So I realized that there were about 300 qualified pulmonologists in the state, serving about 70 million people. So I met about 250 of them in their clinic. And my pitch was quite simple. I said, when you're ready to give up on a patient, send them to me. If you don't like the results, don't send another patient. And if you like the results, then you can send me your easy ones, your easy cases, right? And then I also went back and set up this team and set up protocols. We got the latest technology. It was expensive, but I sort of learned how I could negotiate with vendors and companies to get it at the lowest price possible. We had to figure out how to price the surgery because in India, it's usually self-pay, so they're very price sensitive. And the price sensitive, not to just be price sensitive. For many people, they'd have to decide if they're going to sell their house to have the surgery. So this is real. So we wanted to make sure that the hospital and us as an institution wasn't being greedy. We wanted a financially viable program, but we wanted to be as affordable as possible. So there's a lot of financial engineering around just the product. And because the first month I had nothing to do, there were no patients. I built my own website, did my own search engine optimization. I didn't realize, but I was marketing my program, right? So all the things that we learn in an MBA, I was learning and figuring out right there. And the results were incredibly gratifying, right? In about 6 to 9 months, we built the largest such program, I would say, in South India at the time, for sure. And there were patients coming from all over the country to have their complex surgery done by us. We had a regional reputation already. We were developing a national reputation and so on and so forth. I had the opportunity to train a bunch of surgeons. I would go any place that called me to operate, I would go do the case for free, never charge a fee, because my goal was to popularize thoracic surgery. I wanted to show people that this could be done safely and at an affordable price point, and that there was enough business there. Because once you show people what's possible, people smarter than you will learn how to do it. You just have to show them it's possible. And so it's very gratifying now. I mean, thoracic surgery has evolved to a fantastic degree in India now. It's fairly routine to get lung transplantation now, uh, and it was wonderful to be part of that journey, right? Really impactful. But that was actually the reason why I ended up sort of doing the MBA later on.
I was just going to ask you the relevance of or the parallels between your MBA and what you were doing already. You were marketing, you were building a price. How did you understand this? How did you know what SEO was or what marketing was or inventory? accounts receivable.
I did it was not sophisticated, right? The way I did it was just simple math, arithmetic, right? This is the margin you want to hit. So you want to keep the price low. This is the affordability. This is what we thought patients would be willing to pay. So how can you preserve that, 10 or 15% margin and price everything else accordingly? What we did was just simple, arithmetic. And then when you have time on your hands, and the first couple of months we didn't have many cases, what are you going to do? So I learned what search engine optimization was at the time, and it's not complicated once you put your mind to it, right? So we had time, and I had energy, and I learned on the roll. But this is the big epiphany for me, right? When I went to India. So at the time, innovation to me meant innovating in the lab, finding a new drug, or innovating in surgery, doing a new operation, for example, right? But what struck me is the impact I had there based on reengineering the process of healthcare delivery. The surgery I was doing was no different than what I was doing in the United States. There were a few tweaks because the pathology is different, and where you want to spend money during the surgery is different. And so, yes, we modified surgery a little bit, but by and large, right, the principles were the same. So I wasn't really doing too much innovation there. But the way you innovate about how you deliver care can have an outsized impact on the community around you. And that is what, as I mulled over what I'd done and reflected on what I'd done, I realized that that is what I'd actually done. And to me, that was a turning point. And so I said, well, if I'm going to come back to the United States and do this and innovate in the field of healthcare delivery, innovate in how healthcare is delivered, I need to be better equipped intellectually, skills wise, training wise. And I said, okay, I'm going to do an MBA. And I decided it's very intentional that I was not going to do a healthcare MBA because I wanted to learn from all fields. And of course, what better program in the world to do this than Wharton, right? So that choice was easy.
Right. So I want to talk about innovation. How are US healthcare systems innovating, not just with technology, because I think that's natural, I think that's inevitable, but how you touched on this. How are healthcare systems, hospitals, clinics, um, innovating on delivery, access and delivery? And is that, you're seeing all of these startups get into the medical space. Is that a kind of a way or a pathway to do that? And then they're just going to acquire? Or is it healthcare systems are just so overloaded that they're just trying to keep their head above water because there's billing, there's inventory, there's staff, there's burnout. There's so many things that you have to monitor and make sure that they all are perfect so that surgery is successful.
So I think healthcare delivery in the United States is incredibly complex because it's not a free market at all. It hangs somewhere between being a free market and being a regulated public utility, somewhere in between. It's because a very heavily regulated space, but it's also competitive. It tends to be, in most scenarios, a very high volume, low margin business, right? So somewhere about every year, right, somewhere about 40% of hospitals in the United States have a negative margin, somewhere in that ballpark, right? So you can imagine, right? So this is a very difficult space. There is the whole process of healthcare delivery, recruiting the right physicians, keeping them healthy, you know, understanding where they're coming from, and getting the technology that they need in their hands. There is this whole element of revenue cycle management, which is complex in its own way because there are three parties here. There's actually four parties here. There is the patient, there is the physician body, there is the insurance companies, and then there's the government. So it's a four body problem. It isn't even a three body problem. So you can imagine, how money moves across all these entities is complex. And so what happens in most healthcare situations is nobody's trying to bite off the entire pie. Everyone's looking at what happens in their own microcosm of this thing. And there are many local, just like they say all politics are local, all healthcare is local as well, right? So it's very much depends on what problem you're trying to solve in the community that you're serving, right? So innovation is going to be very tailored to that. Traditionally, in the healthcare space, we always have been 15 years behind, right? From a technology perspective, especially things like IT and so on and so forth. But fortunately, I think that is changing. So if you look everywhere, you see, people are talking about AI in healthcare, telehealth in healthcare, and so on and so forth. And it's a welcome change that is going to redefine how we deliver healthcare in the future. The model is going to be different depending on the context, and it's going to be highly tailored to everyone's context and what they're trying to serve and who they're trying to serve. But it's here. And I think sky is the limit for those people who are involved in it.
What have you seen lately in AI, and where do you see it going? Is it something that's going to completely take over management or billing? Or I know that radiologists use some sort of AI, right, to help with scans. I think some ophthalmologists use it to find I forget what the nerve is behind that's really hard to find.
The optic nerve and so on and so forth.
Optic nerve,
So,
yeah.
yeah, the two areas in routine healthcare delivery that AI is going to have the biggest impact on is going to be radiology and it's going to be pathology. There have been some bold claims about this replacing radiologists and so on. I don't think so. I think that it will make them more efficient for sure. So maybe we may need a fewer number of radiologists than we have had in the past, and it's going to bump up their accuracy. But the only way forward I see going is human plus AI. It's not going to be human or AI. I think that's a false narrative. And so I think that's where the field is going to go. Now, in the more mundane tasks, where you're talking about, for example, dictation, like ambient AI, or you're talking about revenue cycle management, I think the effect there is going to come pretty soon because those are sort of artificially created tasks that are not of much value to anyone or not actually of much value in the actual healthcare delivery, right? The business end of it, and it's usually routine and can have an algorithm probably do a good portion of it. And I think we'll see that impact pretty soon over there. If I had to pick two areas, that would be the area. But there are probably 25 other areas that people are working on, and it's exciting to see what's happening.
Do you see AI and machines taking over your position, just like LASIK eye surgery? I believe that the machine kind of takes over, the doctor's there to monitor. Do you see that happening?
Not anytime soon. I don't think so. Not anytime soon. But it does help with some things. Now there are modules on the robot, for example, where you can upload a patient CT scan and practice the steps of the surgery before you actually do the surgery, right? So in some ways, I think it's going to shorten the learning curve, especially for trainees. But I would say I would find it difficult to think of a day where you would just trust a robot to do the surgery. At least not yet. Not a, yeah, not in my career lifetime. I don't think so.
Are there countries out there practicing this or inventing this?
No, I think there might be portions of. I've heard about some robots helping with so maybe a knee replacement or something like that, but I don't think they do the entire thing independently by any means. They may be doing portions of it, maybe, but that's it. I'd find that difficult to anticipate that. Maybe I'm just in denial. Who knows?
No, I think you're right because people want to talk to a human when they're paying their insurance or they're, wanting to return something. I do imagine that people would want to talk to a human when they're being put under and their life depends on it. And from a Wharton perspective, you could charge a premium for that.
Yes. A few years ago, I bought a Tesla, and I was amazed at the FSD on a Tesla. Within half an hour of me buying it, it got trained, and it drove me back home. I just wanted to see how it works. Do I use FSD today? I don't. Right. So
Interesting.
there is a leap. There's a leap of faith between what works very well versus giving control to it. I think there is a psychological leap of faith. So if people are not willing to let their car drive them, how many will be willing to let a robot operate on them?
That's true. I have a Tesla and I use FSD full time. Chris, I need to hear your perspective here.
I can't go back. I'm all in on FSD. I think the change could only take one generation. I think I remember one professor talking about how our grandkids will not have driver's licenses.
I can tell you, I think that if I had to choose between my teenager driving a car and FSD, I think the decision is easy. But if you actually do a poll, and Chris, you may be right. Maybe all it takes is a generation, and maybe people will be comfortable with that. But when it comes to healthcare, somehow I have the feeling that, at least for surgery, for diagnostic decision making, for treatment decision making, I think it's going to happen sooner. I already have a bunch of my own family members. Before they come to me for advice, they say, well, this is what Google told me, or this is what, Claude told me. What do you think? And that even my 80-year-old dad does that all the time, right? He'll run his report through AI and then say, well, this is what the AI told me. What do you think? So I can see that happening. But surgery is a little bit different, I feel. But again, I may just be in denial, Chris.
I don't think so. I agree with you. I think with certain things, people are willing to, let the car drive to make it easier for themselves. But when it comes to healthcare, I think people really think twice. That's why they get second, third opinions, especially here in America, just to feel more comfortable. And it all depends on, well, the doctor didn't give me attention. The doctor really was thorough.
It's amazing, like true expertise makes such a big difference. True expertise. So there's a recent paper published, and one of the authors is actually one of our Vemba classmates. He's a head and neck surgeon. His name is Ben Roman, and he published a paper out of Memorial Sloan Kettering where they look at the benefit of second opinions and how often when a patient reaches out to an expert cancer center for a second opinion, how often it changes the trajectory of that patient's care, right?
Interesting. In what way?
Sometimes the diagnosis is wrong. Sometimes the pathology needs further workup, and with an expert pathologist, it changes. Sometimes the treatment approach is different. It gives you pause, right? If there's so much variability between physicians who've trained for so long, right, to do this, right? I wonder, right? And that's where expert opinion still matters.
As a physician and a person with such expertise and such determination, how do you deal with error? How do you keep moving forward?
So there are sort of three kinds of errors, right? So one is, error from carelessness. You know what needed to be done. Someone was careless, didn't follow a protocol, or didn't do what's necessary. That's a human management problem. That has a different solution. And then there's a second level of error, which is, well, maybe it's a misjudgment, right? And maybe you could have done something else at the time. And this is something we discuss in what we call mortality and morbidity reviews as a group, right? So every time there's a complication, we actually get together as a group, we review all our complications, and there'd be 6 or 7 surgeons sitting there and saying, well, maybe we could have avoided this by doing this differently next time, a different approach, or and so on and so forth. And it's an honest discussion, right? And there's no seniority or anything like that. It's a safe space. Everyone says what they feel like, and it's one of the rich traditions of American surgery, having that M&M. So that's the second way of how you would. That's the second kind of error that you fix, and with time, the group learns from everyone's mistakes, and I would say misjudgments. I wouldn't call them mistakes, misjudgments, and then you get better. And then there is a third kind of error, which is you wouldn't even call it error. You would just call it variability, right? Because when you think about an operation, right, there are 1,000 variables. And it's impossible to know all of them. It's impossible to account for all of them. So there is going to be, no matter what you do, there's going to be a certain complication rate, right? Just by virtue of not just this being a human enterprise, but also from this being a biological phenomenon and so on and so forth, because you cannot control how everyone heals, for example. We haven't understood very well, because there are, again, probably, 5,000 genes that impact how a person heals. So that you cannot do anything about, right? And so you have to just accept that, and that's part for the course. So it's important to classify each error into these categories and to see, because you should not mistake biological variability for a judgment error, for example. Right?
Right, right.
That's going down a rabbit hole. That's not going to get you anything. So that's how I would classify the errors and the solutions.
And today, when you're teaching your fellows, is that the same methodology you're using for them? Carelessness. Okay. Yeah.
Yeah, pretty much.
And
And carelessness can be avoided by protocolizing most things and having, checkpoints and so on and so forth, right? And so the more robust a healthcare system builds it into its system, the safer things are going to be.
I would say it's not necessarily carelessness just because you weren't fully in the moment. I think we have to consider a lot of things like COVID, the physicians see burnout. That was huge. And were you practicing here in the States at that time?
Absolutely, right. So I was in the front and center because, we deal with airway and so on and so forth, right? So we were very much involved in the COVID thing. Burnout is an interesting problem, right? Interesting, not in a good way, but burnout is interesting because most of the time people assume that physicians get burnt out because they have to work hard. I don't think so. I think physicians get burnt out because they're asked to do things that they don't feel they should even be doing. Right? So physicians love taking care of patients. And as long as you're taking care of patients, I think you're in your sweet spot. But the moment you say, well, you've got to write 2 pages of notes, otherwise you're not going to be reimbursed, or some other nonsense, right? That's the part I think that leads to burnout. Because physicians are very, by and large, the bad eggs everywhere, but by and large, physicians are very mission focused people. That's why they got into medicine. Because, if it's about making money, there are far more efficient ways to make money than being a physician.
And would you say that, going through COVID, coming out of COVID, things have started to normalize? You're starting to see some other things come up with GLP, with peptides, with all of these quick fixes. Would you say that these peptides that everybody's taking, does this have a correlation with cancer growth? Does it have any type of impact on the way those cells are reformed?
Well, thanks for asking because that's actually one of my research projects. So, not so much peptides, but definitely GLP-1 receptor agonists. And so, my entire research program is focused on how obesity impacts cancer, particularly lung cancer. And obesity does bad things if you have cancer because it helps the tumors actually grow more, it dampens your immune system, and all of that. Interestingly, what our experiments have shown is that when you give obese, in this case mice, GLP-1 receptor agonists, the cancer growth slows down. Interestingly.
Interesting. It's negatively correlated.
Yeah, it's negatively correlated. And I think it's a huge area of investigation. Some clinical trials are underway. We actually have now one clinical trial open based on our work in lung cancer that is starting soon. And then we are pitching for another trial with the NCI to do this for lung cancer prevention. It's a fascinating area of investigation, and we don't know where things will come back. Certainly, from when they reduce obesity, they take away a lot of the negative effects of obesity on cancer, which are well known and well documented. So that will help. But what else happens over the long run, time will tell.
Is this something that is new research and also affects non-obese people in the same way?
Yeah. It doesn't affect, surprisingly, it doesn't impact non-obese. I don't know about people, but it doesn't impact non-obese mice the same way. So if you give the drug to a mouse that is not obese, the impact on tumor growth, it's there, but it's much, much smaller. It looks like its primary impact is taking away the negative effects of obesity on cancer, which is interesting.
Whatever's feeding the cancer in obese mice, this GLP-1 is taking that away from the cancer growth, if I'm correct.
We believe is so there's an immune system that limits cancers from growing, and it tries to fight cancer. And in obesity, that immune system is weakened, which is one of the reasons why cancers grow more in obese people. And we believe that that decrease in anti-tumor immunity is mitigated by GLP-1 receptor agonist. And so that's how we believe it works. There may be other ways it works too, but that's our focus.
And you had mentioned not really peptides. Is there a big difference in both of those?
Well, sometimes there can be, because peptides are an unregulated market by and large. It's surprising that they're widely available, but they're by and large an unregulated market. When people start taking peptides, you don't know what the quality of the peptides are. You don't know what the batch-to-batch variation, because again, it's unregulated. Some of them have more effects than just GLP-1 receptor agonists. We are not sure exactly what the dosing is. All of those are questions. People use them all the time. I know people who use them, right? Especially people who go to the gym a lot. I would just urge caution.
Have you worked with any patients that have tried fasting through their cancer treatment? Does that have any impact?
There's a large amount of data that suggests that it actually decreases cancer growth. Actually, one of my colleagues is doing is doing some research on how a keto diet, for example, right, which is a sort of fasting, is changes, lung cancer growth. So again, it's the data around that is promising. It's not there yet where we would openly recommend that, but I think we'll see some readouts from trials pretty soon.
That's really interesting. Yeah, I have tons of questions on that, but I'm just still trying to wrap my head around the GLP-1 in obese mice and the way it's negatively correlated. That's really interesting. So fasting could help, and lifestyle, gym, cardio, any of
Absolutely,
that, it would help.
absolutely.
Okay.
Because when your muscle grows, muscles release chemicals called myokines, and myokines have anti-cancer effects. I think emerging data on that is going to clearly show that, and definitely exercising will help.
I really appreciate that insight there. And before we check out, I would love to ask you the question of Wharton and your experience there. And then also, I know you do a lot of philanthropic work, a lot of, like you said, pro bono work. What are you doing today?
The first thing is I'd say was a transformational journey for me, because you take 2 years thinking about things that you've never thought about. Because look at it from my perspective, I've been seeing patients since the age of 18. And so medicine is sort of almost all I know. And meeting people who are younger than me, smarter than me, have done so much more than me, it was just fascinating. And learning from them was a fantastic experience. Those 2 years I really treasure. With regards to pro bono work, so my sister and I have this foundation called Next Step Foundation. She runs it, I support it from the outside. And what she does is through this foundation, we support, we feed, clothe, and educate 300 kids every year in India. So I told you the story of my grandmother who did the old age welfare center, old age home. So when the construction of the old age home, there were laborers, and she saw that the laborers' kids were really not going to school because they couldn't afford to. And education is a big thing in my family. And so she said, well, this is ridiculous. We've got to build a school. So she builds a school for them, and it's free. And so we took that over about 20 years ago, and we now fundraise for it and run it and support it. And in addition, we also give scholarships to students in need who want to go to professional school, particularly engineering school. And I think this last year we supported our 100th student through their school. So, for us as a value system, education, I think, is very important. It can change your life. And so we do what we can, uh, to support students in need.
Yeah, absolutely. I applaud you for that. And I think my experience was the same thing at Wharton, was just being surrounded by experts and people that have actually done it. And you leave the classroom with incredible knowledge and wisdom from the professor, but also from your classmates sitting next to you, answering questions in real time. And there's always an expert in the room, and it was just an incredible experience. And so, what's next for Sai? You have check, incredible career. You've come from so much. You've checked off the box of the best business school in the world. You implemented that. You're building your internal hospital systems. You've worn the CEO hat. You've worn, the top surgeon hat. You've worn all these. What's next?
So I think I have a few more years building this network, because one of my motivations, as you can see, is providing access to care. And, my dream is fulfilling, at least partially, of Roswell's mission of providing cancer care to all of rural upstate New York. And we've just started that journey. It'll take us a few years, and I'd love to see it through. Devise new ways of delivering that care so that everybody in upstate New York has access to what we do that's special at Roswell.
Awesome, Sai. Thank you. I really appreciate you joining us. This was an incredible conversation. Thank you.
Thank you. And thank you for the invitation, Mark.
Legal disclaimer. The views, opinions, and statements expressed in this podcast are those of the individual speakers and do not reflect the views of their organizations or the producer. This content is for informational and entertainment purposes only and should not be construed as medical, financial, legal, tax, or investment advice. You should always consult appropriate professionals before making decisions related to your health, finances, business, or legal matters. References to any companies or services do not constitute endorsements. The producer and participants disclaim all liability for actions taken based on this content and make no representations as to its accuracy or completeness.